Good morning. Once again, it is a lovely day here in Buffalo, New York. Welcome to the Great Lakes Health Radio program on Power 96.5 FM and WUFO 1080 AM. I'm your host, Francesca Messiah from Kaleida Health, Manager of Workforce Development, and I want to thank you so much for stopping me in the community and asking and having a response when I ask you what you would like to hear. And can I say I'm still working on the orthopedic program? We're going to have an orthopedic half hour before before the end of the year. Speaking of which, the Great Lakes Health Radio program is now an hour. It's from 7:30 until 8:30 every Saturday. The second and fourth Saturday is myself. The first and third Saturday is ECMC. My format is we will have two separate half-hour interviews. So don't turn off the radio at 8 a.m. because there's another program right behind it. Well, today's topic is one that is not only is it near and dear to my heart, it's near and dear to many African Americans and people of color, and that is stroke. So I just want you to know our topic for today is stroke. But first, who is Kaleida Health? We are the hospitals: Buffalo General Medical Center, Oishei Children's Hospital, Gates Vascular Institute, Millard Fillmore Suburban Hospital, VNA, Visiting Nursing Association, which covers 8 counties of Western New York, 24 hours a day, 7 days a week. We're at DeGraff Medical Park, and we're also in Olean and Bradford. We have clinics on Hurdle Avenue, Hurdle Elmwood. And those are for adults. We have a Niagara Peds for children, as well as a pediatric center on Broadway Avenue across from the Broadway Market. We have 2 women's health centers, one on Kensington on the ECMC campus, and also there's a women's health clinic on Niagara Street near Tops Market. And we have 2 long-term care facilities, one at High in Michigan called High Point, and the other one in North Tonawanda at DeGraff. If you're interested in seeing any of our past programs, you can put them into your PowerPoint. You can share them with your class, with your students. You can do multiple things with them. Please visit www.kaleidahealth.org/video. Again, that is www.kaleidahealth.org/videos for past programs. Kaleida, we're doing presentations on healthcare as well as workforce development. And if you're interested in a job at Kaleida Health, please visit kaleidahealth.org/careers. Come grow with us at Kaleida Health. Well, enough of that. On with our show. Stroke prevention and education is a topic we are discussing today with Dr. Amit Kendall. Hi, good morning, Dr. Kendall. Am I pronouncing your last name correctly?
Yes, Francisca, good morning.
Good morning. And what is your title? Dr. Kendall and I are on the Stroke Accreditation Committee, and he's a wealth of knowledge, as many of our colleagues are. But Dr. Kendall, could you please share with the listeners your title?
Sure. So I am one of the neurologists at Buffalo General and University at Buffalo. I'm Associate Professor of Neurology, and I am also a stroke director for Kaleida Health and a clinical research director for Department of Neurology.
Oh, thank you. Thank you. And neurology, that is another topic we will have to have because I just know someone recently who had a brain bleed, and I'm just fascinated with the brain. It fascinates me. But stroke is today's topic. So could you just share with our listeners what is a stroke, and the most important thing, what causes a stroke?
Sure, Francisca. So, stroke is one of the most dangerous as well as one of the most debilitating brain disease, and it's extremely common. What happens with the stroke is there is a problem with the blood vessel in the brain, and either there is a blockage in blood vessel that prevents blood supply to the brain cell, or there is a rupture of blood vessels, and that causes a bleeding in the brain, thereby injuring the blood, injuring those nerve or brain cells. So stroke as a term, it basically indicates that there is a sudden interruption of blood flow to either brain, retina, which is the back part of the eye, or a spinal cord. And that's what we call a stroke. There are many causes of a stroke. But 80%, 8 out of 10 strokes are related to very common risk factors. Before going to risk factor, let me kind of introduce the entire spectrum of stroke. So the most common type of stroke is what we call ischemic stroke. And by ischemic stroke, what it means is there is either problem with the blood vessel or there is a clot sitting in the blood vessel, and that prevents blood flow to this part of the brain. Now, if that blood vessel obstruction or blockage, if it resumes itself or clears itself, then all the symptoms will be resolved immediately. And that's what we call transient ischemic attack, or TIA. But if the blood flow does not resume, then that brain cell cannot survive, and it will lead to a permanent injury, and that is what we call ischemic stroke. That's the most common type. Almost 75 to 80% of stroke in United States are ischemic stroke. That means clot or blood vessel problem. Now, the second most common type of stroke is a bleeding stroke. In this case, there is some problem with the blood vessel. So either blood vessel ruptures inside the brain or in the brain tissue, or outside the brain in the covering. And this is what we call hemorrhagic or bleeding stroke. And there are different types. One is called intracerebral stroke, which means that the bleeding occurred inside the brain. Second one is called subarachnoid hemorrhage, and this means that the bleeding is occurring on the covering of the space outside the brain tissue.
Thank you. You know what? And I want to say that yeah, sometimes it's all fascinating. So let me tell you. So one time I remember I was having a conversation with someone, and we were talking, and they were all of a sudden they became extremely forgetful. And I said to the person, we were talking, and all of a sudden they just started asking me questions that they knew the answer to. And I called the hospital, and an ambulance came, and they kind of jokingly said, you're calling an ambulance because I answered the question wrong. But having been a part of this committee, my concern was all of a sudden, then they kind of started rambling. But my concern was they were asking me questions that for years, it was about cooking. I don't really cook. So for years, they knew I didn't really cook. And I just noticed that, and I did call the hospital. I did call an ambulance, and they had a slight brain bleed, and it never happened again. But then I know other people who have had brain bleeds, and the brain hasn't stopped bleeding. So are both of those, so you're saying both of those are forms of stroke?
Yes. Most commonly, we call the clotting stroke, which is ischemic stroke, as a stroke, which is more common. It's 75%. Other 25% is the bleeding type of a stroke. Like if we go to Asia, then they have more bleeding type of a stroke. So that could be 60 versus 40% in that community. So it all depends on where we are and what's the major risk factor.
Yeah, and I guess being on, I'm not clinical. I just share with people if you see something wrong, something's not right, then to call 911. Is that good advice for coming from a non-clinical person?
Yes, yes. Couple of I'll explain why that's the right approach. So first is stroke is a debilitating as well as a really dangerous condition, which if we look at the United States, it's number 5 cause of death. If we look at the minorities, then it is number 3 to number 4 cause of death. So if we act immediately, then death can be prevented. Now, the second thing and the other most important thing is that it's a number 1 disabling disease in the world. Whenever someone has a stroke, it will leave a lot of disability. So the earlier we can address the stroke symptoms, signs, better is the outcome. That's number 1. Number 2, the hallmark for stroke is a sudden change. Whenever there is sudden change related to behavior or some other things related to brain, then that's a stroke until proven otherwise. And it's always better to first evaluate to rule out a stroke, then think of other things, because we can treat a stroke, we can prevent a stroke. Now, in terms of symptoms, there are many things that our brain does. But I usually say that I usually ask all my patients to watch for 5 major symptoms. And these 5 are not exclusive, like there are others as well, but these are the most common 5 symptoms. Number 1 is confusion, whether it's trouble speaking, trouble understanding, or there is a change in the speech in terms of slurring of speech or word finding difficulties. If that happened, then that's one of the major symptoms of the stroke. Okay. Number 2 is difficulty with eyesight. So either there is trouble seeing in one or both eyes, or there is a sudden onset blurring of vision that was never there. Then that could be a sign of a stroke. Third is trouble walking. It could be dizziness. It could be vertigo. By vertigo, we mean that it's a spinning sensation that someone is having. So it could be lightheadedness, it could be vertigo, or it could be any type of difficulty walking. And then there is severe headache or new type of headache. If a person has a migraine or some other type of headache, and now they are having a new type of headache in terms of character or in terms of intensity, then that should be immediately addressed. And then one-sided numbness or one-sided weakness. And this numbness or weakness will involve face, arm, or leg, all 3 or one of those. And if someone is having these 5 symptoms, then the best thing to do is to call 911.
Yes. And I'm just taking the questions a little out of order. I know someone had once said that if you think you're having a stroke and you live alone and you call 911 to leave the door, and if you're able to talk to the operator, to leave the door unlocked, not open, but unlocked for the EMS person to get in. Is that true?
Yes, I mean, the time is the most important. So whatever it takes for EMT to evaluate that person and transport that person to the hospital, we need to facilitate everything. Now, one of the major difficulty that we are encountering with stroke treatment is that many people, just because of the disease itself, they may not realize that they have any symptoms, and family member may not realize that they have the symptoms. The optimal outcome can only happen if everything is done in a right way, that the person recognizes or the family member recognizes the symptom, they call 911, EMT recognizes the symptom, and they bring that patient to the stroke center, and in stroke center, they get the best treatment there, then the outcome will be the best.
I have a question. So if someone is, let's say someone is having difficulty speaking, or they just kind of froze in the middle while they were talking, they went to the hospital, and the hospital has diagnosed that it's not a stroke. Should they follow up with their primary care to make sure? I mean, is there a way of sometimes a stroke going undetected?
Yes, I mean, stroke is a difficult disease to diagnose. If it's a mild symptoms and if imaging, MRI, CTs are negative, then what we do in the hospital is we evaluate them based on the symptoms. If symptoms last more than 24 hours, then that's a stroke. If it lasts less than 24 hours, then that's what we call transient ischemic attack, or TIA. In both conditions, what we do is we do the evaluation to rule out any problem in CT or MRI. And even if we don't see any major thing, then what we do is risk factor stratification. Stroke is the disease of risk factor. So we look at all the risk factors, thinking that this event could have been a stroke or a TIA. So in that case, what we usually do is we try to stratify all the risk factor and then treat those risk factor. And we always recommend patient to follow with primary as well as a neurologist during that evaluation. And it all depends on what we feel. There are other diseases as well, other diseases of the brain, whether it's a seizure, whether it's a dementia. Those can also cause this type of sudden onset problem. But again, the first order of business is to rule out a stroke before thinking of anything else.
And, and on that line, again, I'm always having conversations with people in the community. And I don't know. And people will say, well, I thought so-and-so had a stroke, but it was only a TIA, which is what, a temporary? I forgot what TIA stands for.
It's a transient ischemic attack, which means that there was some problem with the blood flow, but it resolved by itself. So that's why they don't have any symptoms at that time. Is
having a TIA important to take care of, follow up? Is that something, if someone loved one has a TIA, that that they or you should be concerned about?
Yes, absolutely. TIA could be a precursor of a stroke in 12 to 15% of people. What it means is if someone has a TIA, then there is a 12 to 15% chance that they will have a stroke in next few days to weeks. That's number one. Number two is if someone has TIA, that puts them at higher risk for even heart attack and other blood vessel related problem in the body. So nowadays, what we do is we put TIA and a mild stroke together, and the treatment and risk factor modification and everything is same. So we do take TIA extremely seriously in terms of controlling the risk factor and preventing the stroke.
So if someone has had a TIA, is there anything they can do immediately with their diet to any prevention or yeah, well, I guess that's my question. If someone has a TIA and it's not, they went to the emergency department, they said it wasn't a stroke, are there any modifications they can do to try to prevent it from happening again?
Yes. So what we do is if we diagnose someone with TIA, then we start them on a blood thinner medication, whether it's aspirin or the second one called clopidogrel. If it's a high risk TIA, we do add both of those for 3 weeks. And we do start cholesterol medication, we usually go with the high dose statin, whether it's atorvastatin or rosuvastatin, and then we address all the other important risk factor, being blood pressure is number one, diabetes, cholesterol, body weight, smoking, physical inactivity, sleep apnea, and others. So all of those has to be addressed. And if we start those prevention medication with cholesterol and blood thinner, along with that, if the blood pressure, diabetes, physical activity, and those things are in place, then the next TIA or stroke can be prevented.
How about can strokes run in families? Like, your mother, your father, your grandfather, your children, your grandchildren. If your grandmother was at a greater risk of a stroke, does that mean that grandchild or family member might be at greater risk of a stroke?
Yes. So there are genetic stroke risk, which are not that common, but there are genetic risk to all the risk factor related to stroke. For example, high blood pressure, diabetes, those things do run in the family. And then our natural activity tendency also, those also does affect how the stroke risk factors are shaped during the lifespan. Now, if we look at the distribution or lifetime risk of a stroke, and if we look at 18 to 65 years old, in the United States, it's almost 25% lifetime risk. What it means is 1 out of 4 people can have a stroke in their lifetime, and those are related to the risk factors. And 80% of those are preventable if we act in a right way during our lifetime.
Mm-hmm. Act in the right way. If you could elaborate on that a little more.
Yes. So there are a few things that will simplify this understanding. So we have our brain cells. We are born with those brain cells and blood vessels. If we have a genetic problem with those blood vessels, then we tend to have more stroke than people who do not have those genetic problems. But it's not all about what we got in terms of the cell. The risk-taking behavior of the entire life does have higher effect. By risk-taking behavior, what I mean is, if we have smoking habit, then smoking will affect those blood vessels. So gradually the wall of the blood vessels become weaker and the blood vessel will be narrower. And that does affect the future stroke risk. Similarly, if we have a high blood pressure, and if we don't ignore that high blood pressure and we start the treatment, we limit those salt and other high calorie product, then over the time, that blood vessel would not be impairing or damaging those blood vessels. Similarly, our diet, or many people have this familial high cholesterol level, and those will have to be addressed with the right medication. Similarly, the physical activity. It's proven that people who do the regular exercise, whether it's a running or whatever type of exercise, what it does is it prevents a stroke. And even if a stroke occurs, they tend to recover better than people who do not exercise.
And walking is good. And walking is good too.
Correct. So it all depends on whether we have those risk-taking behavior. If we don't have those risk-taking behavior and we are taking care of all the risk factors, then this is a preventable disease 80% of time.
Okay. And I know we are really running out of time, and I know we're going to have a part 2. And now that the show is an hour long, I can send you an email so we can extend the we can extend the conversation. But Gates Vascular Institute, someone isn't, you observe one of these behaviors, difficult with eyes, confusion, severe headache, trouble, walking. Who should they call? When they call 911, can they tell the EMS driver that they want to make sure they take their loved one to Gates Vascular Institute?
So it all depends on where the person is. If Gates Vascular Institute is within 10 to 15 minutes of the duration from their home, then yes, that's the place to go. And I'll explain why that's the right place. But it all depends. If someone is 1 hour away from Gates Vascular Institute, then we want them to go to the nearest stroke center so that they can address the time-sensitive issue, and they can always contact the Gates Vascular Institute for the next step. What we don't want is people driving or family member driving them from home to the hospital. That will delay the treatment. The most important thing in stroke, entire care is the time. So we need to make sure that we are not wasting time in the transport. So if you are closer to Gates Vascular Institute in 10 to 15 minutes duration, then that's the right place. If you are further out, then the nearest primary stroke center, and they will contact Gates Vascular Institute for further guidance in terms of care.
Well, thank you, Dr. Kandel. We have about 30 seconds left. What are two of the most important points you want our listeners to know in this part one conversation on stroke prevention? What are two of the most important takeaways you want?
So the most important thing is stroke is extremely common and it's a preventable disease. So we need to start thinking about stroke prevention by limiting those risk-taking behavior and improving our health behavior by addressing high blood pressure, physical inactivity, diet, and body weight. That's number one. Number two, stroke is a disease which used to be a deadly as well as disabling disease, and now we can help. But you have to be in the hospital on time in order to have an optimal outcome. So what I would say is always act fast. By fast, I mean if you see face drooping, if you see arm weakness, if you see any speech difficulty, call 911. Do not call your primary, call 911. That will ensure that the process will fall in place and you will have the best outcome.
And if you're living alone, if you can call someone to help you there, because that person may have to speak for you in the hospital. Because if you're unconscious and you're that person, you know them well. I'm not saying you're their health proxy. I'm just saying if you know them well, please go to the hospital with them. Because if you're unconscious, there's nothing that, I mean, it's not nothing. I shouldn't say that. It's just more difficult to communicate with the person if they're unconscious. So if someone's calling you and says, I think I'm having a stroke, please stop what you're doing and get there and help them out. But Dr. Kandel, it's 29 minutes and I have to say thank you, and we will have another conversation. So thank you, Dr. Emmett Kandel from Kaleida Health, neurologist, expert in the area of stroke. So thank you so much for being our guest today on the Great Lakes Health Radio program.
Thank you, Francisca, and thank you for having me and having this discussion about such an important disease. Thank you.
Yes, and this is part one. And I just want to say thank you. Okay, I'm with the second part of our program. Well, today on the second part, we're talking about patient navigation at Buffalo General, but I believe it might be through the Kaleida system. And our guest for today, we have Dr. Kenneth Snyder. Good morning, Dr. Snyder. How are you?
Good morning, Francesca. Thanks for having me back. Honored to be there, and thanks for all you do for our community.
Oh, no, thank you, Dr. Snyder. And Dr. Snyder, could you share with our listeners your title again?
Sure. I'm a vascular neurosurgeon in the community. I'm vice president of physician quality for Kaleida Health, and I'm co-director of health system science for the medical school.
Thank you. And our other guest today is Katie Weatherall, and Katie is a director of post-acute services for the Great Lakes Integrated Network and General Physicians. Did I get it all, Katie?
Yes, you did. Thank you so much.
Okay, thank you. Well, you know what? We're talking about patient navigation system, patient navigation process, which was begun right here in New York State at Harlem Hospital in the 90s. And now I am so happy to say we have it at Kaleida. However, could you share with our listeners, what is it? What exactly is it? I know it sounds exciting, but I want you to tell our listeners what it is.
Sure. So through the Great Lakes Integrated Network, we offer care navigation services to all patients. And it's really twofold. So any patient that is leaving one of our hospital sites, we are working collaboratively with the attending physicians within the hospitals, as well as our discharge planning and patient management team, to coordinate any follow-up care that they may need, whether that is finding a primary care provider, attributing them for a transition of care visit with a provider they already have in the community, and setting up any sort of specialty care, imaging, or procedures that they may need post hospital stay. On the other side of the house, we work with our ambulatory side with General Physician PC, and we coordinate all follow-up care for patients that are leaving their primary care. So anybody who may need to see a specialist after they've seen their primary, we are coordinating that care through direct scheduling within our own medical record. So it's much easier for the patients to get to the next level of care that they need, get those specialty services or imaging that they need, because we're scheduling it for them right there. They don't need to worry about calling an office or making a decision. We're ensuring that that care is being done for them.
Okay, and you know what? You've said a few words that are kind of clinical. I want to make sure that everyone understands them. Ambulatory. What is ambulatory care? What does that mean?
So ambulatory is outpatient services. So your primary care offices that are in the community. So we at General Physician have several primary care locations throughout Western New York, and we are either working for General Physician, helping our primary care patients that are already established with a doctor to schedule their follow-up specialty appointments or procedures. And for those of our patients that are leaving the hospital that need a primary, we are scheduling them with those appointments. So ambulatory would be your outpatient services or your doctor's offices.
And then another word that you use is imaging. What's imaging?
So imaging would be going to get a CT or an MRI, getting any sort of follow-up at Great Lakes Medical Imaging. That is our partner that we use in the community. That is a part of the Kaleida Health system. So any sort of radiology testing that you need to have done.
Is it a basic X-ray? Does it include that?
Yep, X-ray. Yep, could be X-rays, or it could be, you know, when we say CTs or MRIs, that's a little more of a complicated procedure that you're maybe having done that needs to kind of check things beyond just your basic X-rays.
Okay, all right, thank you. I just want to make sure everyone we're on the same page. Now, why was the program designed, and who is the target audience? I mean, who is the target our audience? Meaning, is it everybody? Is it adults, children? So why was it designed? And I should say, is everybody the target audience?
Sure. So the reason it was designed was actually back during COVID. We had worked collaboratively with patient management here at General Physician to help patients that they were recognizing that either were in the hospital for COVID or some sort of respiratory illness that didn't have a primary in the community to follow up with. And perhaps they were using the ER as a means to get their care. So we partnered with patient management within Kaleida Health, and started getting patients scheduled with primary care appointments, making sure that they had that follow-up that they needed once they were in the hospital. And from there, it evolved to a wonderful partnership with our patient management team within the Kaleida Health system, and decided that in addition to just scheduling primary care appointments, that we could also be supporting patients that were in need of disease management. So that was when we recognized that through patients that had been diagnosed with CHF or COPD, that we were
you're using jargon. What is that?
Oh, sorry. So CHF is congestive heart failure. And COPD is chronic obstructive pulmonary disorder. And those are diseases of the heart or diseases of the lungs and breathing. So those are diagnoses that patients would get, which would require a follow-up in the community with either a cardiologist or a pulmonologist. And you certainly want a primary care involved in the follow-up care and continuous care of those patients. So, as you know, that's a diagnosis that people really need help navigating, as it, those words and acronyms, they can be scary for somebody who's never heard that before. And they really just needed that extra help in the community, getting them to the right doctors at the right time, managing it so they can live their life to the fullest. So if we saw that a patient was diagnosed with one of these diseases, we would contact them and provide a series of clinical follow-up questions to make sure that they're doing okay based on specifically what their disease was, and check on them weekly to make sure, first and foremost, that they're feeling okay. If they aren't, we're making sure they're getting appropriate care within their primary or their specialist. And in addition to that, we are also making sure that they're going to those follow-up appointments, that they have those scheduled. If they didn't, we're scheduling them for them, making sure that they're taking their medications appropriately, and just being that extra little bit of TLC for the first 30 days after they've gone to the hospital to make sure that they're doing okay.
I can't highlight how critically important this is for our patients any more significantly. The patient navigator programs began in oncology because of how complex and how many different people are involved in the care of a patient. And what we've recognized is any chronic disease has this same level of complexity. How many families, how many patients in our community are trying to understand and juggle between multiple different recommendations from multiple different specialists, or need to try and coordinate office appointments, transportation, and follow-up care, and just an understanding of the diagnosis. We as healthcare providers struggle with navigating the complexity of the system. I can only imagine what the patient feels as they're trying to sort through this. In our emergency department and or our primary care physicians also sometimes struggle with, we give the appropriate recommendation. We ask the patient or the family to do the follow-up. What Katie and Dr. Shields, who again, CEO, president of Great Lakes Integrated Network, have recognized is that just telling or directing the people what to do is not enough. We want to help do it for them. The ability for a patient in our emergency department who doesn't have a primary care doctor to leave a visit with an appointment and a linkage is incredibly powerful. That alone will help from a health of the individual and a resource management component that will make a dramatic impact. And again, Dr. Shields and Katie's vision and ability to expand this to anyone that needs it, to have Kaleida's support and Great Lakes Integrated Network support to build an IT infrastructure to be able to link systems that don't talk to one another and have an appointment scheduled. These are massive lifts that will have an incredible rippling positive impact on our community. And I just wanted to reinforce that point.
Yeah, and I have to say, not only is it systems who don't even necessarily talk, sometimes people themselves don't even talk to each other. So to have this kind of a system where someone is able to assist, because many times if you're at the doctor's office, not even at the doctor's office, like you said, you're leaving the hospital. First thing when you leave the hospital, there are so many concerns. I know that many times run through people's, minds, such as they're paying their bills. Are there bills? What does the house look like? And those are things. And then someone saying, and you need to follow up with maybe 4 or 5 other physicians. I think it's a great system. And I have to say, up until now, and doing this radio show, I always, I hate to say it, I always thought congestive heart failure and COPD. I mean, from looking at the commercials, they look like they are the same thing. And I guess it's not till you've been diagnosed that maybe you know that they're different. That there is a difference in the two. But what is it? Just a slight sidetrack, but what is the major difference between COPD and congestive heart failure?
One being primarily the lung is the issue in terms of oxygenation, or the ability for the lung to be elastic and expand and bring the air in like it needs to. The other one being the pump is the problem. The heart itself doesn't have the strength, doesn't have the capacity, is overworked, it has some underlying disease such that it's not able to pump out the oxygen well enough into the lung to get oxygenated and then pump it out to the rest of the body. And so both of them, you can have lung disease or heart disease that leads to not having enough oxygen in the body and the blood to sustain your activities and what you do. Both can leave you short of breath, which again may be why, Francesca, it makes sense that can be the issue. We then need to sort out, is it a lung problem? Is it a heart problem? Is it both problems? And how do we optimize? And again, what the point that you're bringing up is, they often start to get above the general knowledge base and treatment paradigm of a primary care doctor. You now need to have a heart specialist, a lung specialist, both specialists, different treatment options and plans and risks and benefits that need to be sorted out, multiple appointments that need to be coordinated. When can Dr. Shields, Katie, and their team, and or our Visiting Nurse Association, which is an unbelievable gem in our community to be able to deliver home care, start to get to someone's house to do an assessment, make a tweak with medications, use telemedicine to save someone from a pathway or trajectory to end up needing to come back to the hospital for their care. And again, Katie and her team are a lot of the linkage points for these assessments.
Mm-hmm. And I have to say, I know one of the things, especially when I was in the community doing more of on the health side, now I'm doing more on the job side. However, I still recommend the same thing, and I'm asking. So when someone is making do they make an appointment to see a patient navigator, or do they see the patient navigator before they leave the hospital?
Nope. So everything is actually done virtually. So our providers, and I'll use the ED as an example. So our providers in the ED send a referral within their electronic medical record over to our team, and our team receives that in live time. And typically they'll wait about an hour or two just to make sure the patient's had time to get home, kind of get their bearings about them. Although there has been times where they've called them while they're still in the ER waiting room. And they make sure that they're contacting that patient and scheduling them based on the best time for the patient. We really do, especially if they're a new patient in need of a primary care appointment. We're really trying to get them in, if not the next day, between 48 and 72 hours, just so that momentum is not lost with making sure they're getting that transition of care, evaluation and follow up with their primary. It's almost like an email through EMR to EMR.
Okay, I have a couple questions. Well, that's the first one. I know you can't make anything mandatory, but how strong on a scale of 1 to 10 do you encourage the patient to have somebody with them during the conversation?
The conversation, do you mean
during the conversation about next steps, primary care, only because a lot of times people may not tell their family members the truth, meaning you could have this long conversation with them, and then when it comes, then the family member will say, oh, so what did the hospital say? And that person might say, not too much. So in terms of, I always recommend, that person brings somebody, the patient brings somebody with them, because a lot of times you're scared. You're not going to admit that you're scared, but, it's just nice to, bring someone with them. So I'm just wondering, because it's virtual, can you have a 3-way call if that person can't make? So at least it's somebody else hearing what you're telling them.
And Fran,
yes,
Fran, let me add a little context to this, and then Katie can build off of it. What I love about the Katie's program and the Patient Navigator program, we as physicians are obliged to the patient in front of us. And I will tell you, if I believe my patient is competent and understands everything they say, if they tell me, Doc, appreciate your time, I'm not doing anything you tell me, and I'm not telling anybody in my family. Believe it or not, they have every single right and power to do that. It is my job to make the best argument I can about what's important about their health and what they want to do. But if they're competent, if I know that they understand me and get back to me, it is not my obligation to call their daughter, their sister, their brother, their grandmother. Now, that doesn't mean that I don't talk to them if the patient tells me I want you to talk to them. And what I love what you're saying is, people don't process all the time what you think they process. And having a couple extra people around to help, as long as the patient wants it, is a wonderful double check, triple check to help ensure that the patient-centered plan takes place. And this is what I love Katie and their team for. They track follow-up. If the patient doesn't show up, they reach out. They send a letter. They notify the doctors. So I think of Katie and the Navigators teams as that additional family member, as that extra set of eyes, just like you're getting at, in terms of making sure that everything that could be done is done. And if the patient doesn't want it, the patient doesn't want it. But let's be sure it's not something that's slipped through the crack.
Mm-hmm. It's something as a most requested service, let's say. Is there something that you hear patients, once they understand everything, is there a service that seems to rise to the top that patients are concerned about?
From a referral perspective?
Well, just from asking, I mean, a lot of time, I mean, are they concerned about, I don't know. I don't know, but is there a question from a referral? Yes, from a referral.
So, I will say, I'll use our ED departments between Buffalo General and Suburban. So about, we'll say rounding out this month, so August, we've received about 600 referrals for patients who need primary care providers. About 25% of that, in addition to primary, also need cardiology follow-up. But what I will say is, and an absolute kudos to the providers in these EDs, is I think they're having a very thoughtful conversation. To Dr. Snyder's point, they are educating the patients on the benefits of allowing a navigator to work with them. We're here as an added resource for them. And so they're getting that consent and having that conversation with the patient at the bedside, saying, hey, just so you know, when you go home, somebody from our team here at Kaleida is going to give you a call. You don't have to worry about it. We're going to take care of it. All these things we told you need to follow up on, we're going to make sure that we're checking all those boxes for you. We're going to make sure you know directions. They will give them, get them the Medicaid transportation that they need. They will also follow up and say, hey, we also noticed that this patient really needs some help with Meals on Wheels. We'll connect them with any of those kind of social barriers to their care as well. So we're also involved in any of those things. It's our goal to make sure that we are extending our care beyond the hospital stay, and we're taking care of those patients within the community as well. So, driving the point home that Kaleida cares about you all the time. And we're making sure that even past that time that you're being so well cared for by our providers and our nursing team within the hospital, we are making sure that is extended into our outpatient, or as we said before, ambulatory services too.
So now this program really sounds great, almost too good to be true, and I know it is true. So let's say I've been in the emergency department. Well, let's say I was in the emergency department. Then I was, a patient on one of the floors, and now I'm getting ready to be discharged. And your department of patient navigation, doing a lovely job. And how long can I keep you? How long will you help me with my...
So you know what, we've got a plan for that too. So our team in care navigation is episodic. So if you're talking to somebody, we're making sure that you're there. We're getting you through those 30 days after you've gone home. So really about a month. We'll obviously keep people on a little bit longer if, say, they have an appointment that's a little bit further out. If we notice that a patient needs care beyond those 30 days, then what we do is there is a chronic care management department within Glenn as well, and they do a wonderful job of managing patients with chronic illness. We send that referral over to them. It's a warm handoff from our team over to their team, and we're coordinating that long-term follow-up care for those patients in the community.
This is the first year I've heard more and more people, maybe who are living in their 90s, and saying that they can't stay at home any longer. Do you help elderly persons who are a patient due to one of the chronic illnesses, if they need to move into a smaller place? Are you there do you have connections with senior housing to assist with that?
Yeah, so we do this. So this is twofold. So we do have resources for housing. In addition to that, we also have a post-acute navigator, and her role is dedicated. Kaleida Health actually has a large network for post-acute, or what is skilled nursing or subacute rehab. We have 26 providers across 15 facilities within Western New York. So if a patient is leaving the hospital and they're maybe not necessarily immediately going home, they need a little bit of a stay in subacute rehabilitation, we in care navigation are following those patients. And once they're discharged, we're making sure that they're getting the primary care follow-up that they need, that they're getting any specialty appointments. And our providers, which are also primarily general physician providers, have their own dedicated navigator. So if a patient needs help in that setting, we're making sure they're getting the appointments they need, and we're following up with them.
Thank you. Dr. Snyder, is this is the patient navigation being introduced to the medical students, the newcomers into medical school?
That's such a great question. So we've recently started to introduce an entire new pillar of medical education, as we talked about before, called health system science. And it's the it's the science of healthcare delivery, the complexities of care, the handoff concerns. And so they learn about the complexity and learn about potential solutions. And that actually is experiential learning. Being a patient navigator in many health systems or in other programs is one of the experiences we want students to be able to get. And so all of that is being done at the level of teaching them early on in their careers. Again, what I find is that even when we make the right diagnosis and feel like the patient's going to follow up and do things right, we still don't have the outcomes we need because of facets like this. If the follow-up isn't in place, or there's a miscommunication, or there's a link, that can be one of our breakpoints. These programs are key to help implement those. And also the message to the listeners, there's many, but I think if there was one from what Katie had talked about, if you're above 18 years of age and you do not have a primary care physician, this program, Great Lakes Integrated Health, GPPC, UB, this is here for you. That's part of the problem. I mean, the fact that we have multiple people using our emergency departments as office visits is part of the problem. And this program, since its inception, and I haven't seen the most recent data, but the last I looked at, I think 60% of the people that didn't have a primary actually followed up with the primary and had an outpatient appointment. That is tremendous in a short time frame. And that's the important message to people that are listening.
Yes, and that's key. I know in the community when I did more outreach on the health side, many people I would ask, do you have a primary? And everyone said yes for the most part. But then I get into the meetings and I hear about the people who don't have, and I'm just really pleased that Kaleida has a patient navigation program, not only at Buffalo General, but they also, I'm sure they also have it at Millard Fillmore Suburban. So it's serving urban and suburban, because we know when it comes to healthcare, regardless of your level of education, it's complicated.
You bet. And actually everywhere. Katie's actually reached out to Olean General. Katie will help anywhere within an affiliate or with the hospital system to help develop the linkage.
That's wonderful. That's great news. That puts a smile on my face. We only have a couple minutes left. So closing comments you would like to share with our listeners about the patient navigation at Kaleida Health, helping you once you when you're coming out of the emergency department, or you're just being discharged. Bottom line, when you're being discharged.
Yeah, you know what I would say is, for anybody that's listening, if you're in doubt or have a question, or just need an appointment, our phone number, we try to keep it as easy as possible. It's 716-800-CARE. And if it's somebody, if you've just gotten out of the hospital, or perhaps you're just someone in the community listening that really is in need of linkage for primary care or for a specialist, we are here to help. That is what we do. I feel very fortunate. There is a group of about 20 navigators that are equally dedicated to our Western New York population, making it a better place. And they're a magical group of people, because each one of them really goes above and beyond every day to take care of those patients. And we feel very grateful to be able to do that.
Thank you. And Dr. Snyder, closing remarks.
There's a lot of reasons why I'm proud to be a part of this organization. I think Dr. Shields and Katie's leadership in this work, Barb Mistrol from Inpatient, Mike Minio, our team's vision that this is a critical investment to take care of our patients that are slipping through the cracks. I think it sets us up. What I'm most excited about is not just immediately closing the gap on people without primary care, but then the ability to leverage VNA and leverage home resources and leverage home monitoring and start tailoring treatments and protocols for people with complex diseases to take care of them in their houses as much as we can. That's very exciting to me. And this program will be a key piece of that entire protocol and treatment plan.
And I have to say, I have seen it work, and it works. And that whole, imagine no more slipping through the cracks. I mean, that is what we want, to get caught. And if you can't just know that when you come out of one of our Kaleida sites, there's someone there for you to help you navigate the next part of the process after your chronic illness, acute illness. Yeah. So again, thank you, Katie Weatherall with Great Lakes Integrated Network, which we'll have another show on what is Great Lakes Integrated Network, but that's for another program. And Dr. Snyder, Dr. Ken Snyder, I want to thank you both for being our guests today, this morning on the Great Lakes Health radio program. And in 2 weeks, God be willing, you'll hear from me, Francesca Messiah, Kaleida Health. But next week, you'll hear from my esteemed colleague from ECMC, and that's Cindy Bass. And I also want to give a shout out to Joe, our video photographer, for making all of this possible. Thank you, and bye-bye.